Hello class, this is Chapter 8, Special Imaging Applications. What we're going to learn in this chapter is how to find creative solutions for patients and body habitus that present problems to us, how to go back and do additional imaging if we do not capture all of the breast tissue on our basic images, and then how to really work with the C-arm to move it into those special positions. So as we've talked about, and as we all know, everyone is different. We're all shaped differently. Our body parts are different. So there's always going to be a small percentage of patients that are going to require more than our standard 2 projection mammogram for a screening. We're going to have to modify our positions depending on the patient's shape. We're going to have to do some complementary views to make sure that we are getting as much breast tissue in the images as possible. And just keep in mind that positioning is more of an art than an exact science. Understanding how mammography works, understanding the history of mammography, the equipment and so forth is the science. Positioning is more of an art. So we're going to go back to something we learned in a prior chapter, and that's exam management. And here's the definition. It's the technologist's ability to evaluate the imaging compliance during the performance of the standard views, whether the use of supplemental or complementary projections will assist in achieving the end goal, which is sufficient image quality. And we have to ensure that the selection of specific projections to accomplish the objective of adequate tissue capture and in clarity for the imaging exam with the least amount of dose to the patient. So as with any other exam that we do in radiology, we have to weigh that patient dose with having an optimal image. And that brings into account whether to take an extra view or not. So even though you have effectively executed a projection, visualizing all the regions of the breast on a single image is unrealistic. There's no one image that can catch it all. So that's why we have to have the complementary views. In addition, we have to be able to determine if additional imaging is needed and how to manage each of those circumstances. Occasionally, the technologist encounters a patient who presents with physical, emotional, or psychological circumstances that are going to impede the effectiveness of your screening mammogram. And these situations require the mammography exam to be customized to that individual patient's situation. As an example, you may have special circumstances that you have to customize for if the patient is confined to a wheelchair. So part of exam management is to determine that you need additional imaging. Now you have to determine what's the best view. There's many different directions to go depending on the patient's body habitus. Each view, though, should complement the other view. We need to learn to evaluate each view to determine from which quadrant the tissue is missing. Be familiar enough with supplementary projections to choose the most suitable view to complete the study. And the extra view should demonstrate breast tissue omitted from the standard 2 views. It's not going to do us any good if the additional views are not capturing that omitted tissue. We also have to keep in mind that the patient needs to be respected when we're making additional X-ray exposures. They do have dignity that we need to respect. The ARRT Code of Ethics number 2 requires that the rad tech acts to advance the principal objective of the profession to provide services to humanity with full respect for the dignity of mankind. The appearance of us struggling or fighting to execute the examination should be minimized whenever possible. Our behavior or indications by the technologist that imply a difficulty to execute the exam or in problem solving may suggest that the patient is the cause of the problem. So we don't want to put the patient on defense. We need to carry on with complementary views or additional views as if it's just part of our day-to-day process. Advocate using two technologists for mammography procedures that are physically challenging for one technologist to perform. So don't feel like you have failed if you need to go enlist help from a fellow tech. We need to appropriately document everything. An accurate account of the examination specifics should be included in the documentation that is going on to the radiologist. So for example, if you did some extra views because a patient is confined to a wheelchair, make sure that the radiologist knows on the history form that the patient had special circumstances as being confined to a wheelchair. Suboptimal images have been produced and accepted by the technologist due to positioning limitations of the patient. They will understand this then. Modifications to the mammography examination were made using replacement or additional views to the standard projections due to positioning limitations of the patient. So you need to make notifications of that too. Critical documentation should accurately indicate to the radiologist the reasons for the patient positioning limitations that explain the imaging results accepted by the technologist for this particular study. So when you finally have everything that you're going to accept, make sure that the radiologist knows what your limitations were. Here's some examples of non-conforming situations. Implanted medical device. Often there's going to be patients that do have a pacemaker implanted. It's going to project project beyond the chest wall. So you have to be careful of that. Protruding abdomen can cause us a lot of challenges. A very small breasted patient versus a very large breasted patient. A male mammogram, a patient with kyphosis or pectus excavatum and so forth. The first thing to look at when you're looking at your images after making the exposures is to make sure that your mammograms will show all of the fibrous tissue, all of that glandular tissue you can see behind it. You can see that inframammary fat space between the chest wall or the pectoral muscle and the glandular tissue. You should be able to see that. If the image is cutting any of that off, then that is where you have to think about, do I need complementary views? Do I need additional views to show that part of the breast? You have to remember that the breasts come in all different sizes and shapes. So the base of attachment for a breast is different. If you look at breast A, it's a very pendulous breast. And so that base is very confined. And the breast is going to be very easy for you to confine, to move it, to lift it and move it. But if you look at a patient like patient B, the base is very, very wide, very broad. And to really be able to move that breast into position is going to present with some challenges for the technologist. And often these are the shape of breasts where you have trouble getting all of that glandular tissue on. So as I was just mentioning on the previous slide, a small-breasted patient, the breast may be quite firm and have a wide base, or they are going to extend more laterally than they do medially. So it's more of a spread out breast mound. And you may, in those cases, have to use a different type of paddle. Maybe a half paddle, a small paddle, will be a better compression device. It may be difficult to image the extreme posterior breast tissue, as I mentioned, and so sometimes you're going to need that additional view. These are the patients that you need to make sure that the image receptor is raised to the correct intramammary fold height. Sometimes, because those type of breasts don't really have a very well-defined inframammary fold, it's a little bit difficult to really understand where it is. And often with these patients, they're the ones that you're going to do the exaggerated CC of the lateral tissue of the breast, because as we mentioned on the prior slide, their breasts tend to kind of spread out. You want to make sure that when the patient exhales, the compression doesn't move across the rib cage. So the patient needs to breathe very quietly, because them breathing in and out is enough that it could move tissue away from the compression. This is versus the large-breasted. The large-breasted patient doesn't always mean that they're an obese patient. You can have an obese patient that for their size have small breasts and have similar breasts like we talked about on the prior slide. But you can have even petite women that have very large breasts. You want to make sure that you're using the right size of the compression device so that it's compressing the entire breast. Often you may need to do what we call mosaic imaging or tiling of the breast, and that is where you're going to take sections of the breast. It may take 2, it may take 3. Sometimes there could be instances where it takes more, but you always want to make sure that you have a center of orientation. And here they're recommending a BB placed at the center of the breast. You might want to use a compression device that tilts, and that's because a lot of times it may be very difficult to get that breast compressed back towards the base of the breast, and the tilting helps with that. Anterior compression views are often necessary. By the time you get all of that breast tissue compressed, it may not be able to come down enough to catch the front of the breast, the anterior portion of the breast. So you may need to do a separate view to compress the front of the breast. Often these are the types of patients where the oblique angle is not going to be very steep. So here you may be doing an MLO that's only about 20 degrees. Here's an example of the mosaic or tiling image of the breast. And as we mentioned, because the breast is larger than the detector, it has to be imaged in sections. But you have to have a way where you have a common area that all of the tiling catches so that you can make sure that you're getting all of the breast in there. So there's other non-conforming situations, and there's very good examples of them in the textbook. If you look at images 8-10 through 8-11, these start on page 312. They show you examples of the male breast, kind of go over what the solutions to that would be. Of course, they're going to be, you're going to have the same type of issues even more than a small-breasted female, that the breast is going to be small and very firm. The chest hairs a lot of times make it slippery. That chest hair on the breast when you compress it is kind of like trying to compress, something that's furry. It just wants to slide out. This too, you might want to use the smaller compression paddle. You might want to reduce the compression force just slightly, but it's very critical that you include the nipple and profile for men, because pathology is located directly posterior to the nipple, most often in a male patient. Here's a picture of a patient with pectus carinatum, which is what we call pigeon breast, where it protrudes. Sometimes you have to be very careful when you're compressing that you're not unnecessarily scraping or gouging that part of the patient's breast when you're bringing the compression paddle down. A lot of times these patients are going to have a wide breast base, and a lot of times their breasts are going to extend laterally under the arm, meaning that you may want to do an exaggerated CC. And here's an example of some of the views that you would do for a pectus carinatum, and that would be the exaggerated CC, as I mentioned. You may need to do it both for the lateral and the medial tissue. Of course, you would be doing the MLO. You may need to do a lateral medial oblique, where you do the complete reverse of the MLO. Or you could do the superior inferior oblique, because you would be then compressing the breast from the lateral portion instead of bringing it down across that breastbone. Pectus excavatum is where the sternum is sunk in, and a lot of times it makes it difficult to get all the breast tissue on your image plate with this type of body shape. With this, you could do the exaggerated CC views, MLO or the LMO, and then you might need to do a lateral medial view, or you could do the compression, the SIO, superior inferior oblique, where you compress from behind. Sometimes you just need to get the patient up there and kind of try a couple things before you figure out which one really works the best. And another thing too to keep in mind is once you get that patient position and you start compressing, that's when you know if it's working or not. You can let it off, make your adjustments, give another go at it after you've made your adjustments, and now things may be moving more in the direction that you want them to. A really difficult patient is a patient with kyphosis because they are hunched over due to their vertebral deformity. Often these patients have other deformities like a rib cage deformity. They may have a pectus excavatum or pectus carinatum. It just depends how bad the deformities are, and it may change from side to side what's going on with the patient with the ribs and so forth. So sometimes it might be best to have these patients be able to sit down, because then they can kind of ease back a little bit, and you can bring the compression paddle and the detector more towards the patient. But as I said before, you have to just try different ways about going about this. These may also be good patients to try an SIO on, superior inferior oblique, but it just takes time to try different things, and you'll know when you've actually captured the best amount of breast tissue in your under the compression paddle before you make your exposure. There's also some non-conforming situations that could happen. For instance, you could have a patient who has a shoulder injury, or they're post-surgery, or for whatever reason, they don't have the range of motion in their shoulder, so they can't really get the arm up like you would like them to, or move their shoulder out of the way. And it's just a matter of trying different things, moving the height of your detector, gradually raising the patient's arm until they reach their limit, and then just trying those usual different views that we've talked about, the lateral medial oblique versus the medial lateral, or a lateral medial 90 degree. So this is another one that's really, really difficult. Our patients that are hunched over, but what's really causing the problem here is that they have a belly, a protruding belly that actually protrudes more than their breast tissue does. So sometimes it just takes a matter of getting the patient perhaps seated where maybe they can lean forward better. Sometimes if they're very steady on their feet, you can have them stand and lean in so that they leave the belly behind and lean the chest in. These are also patients that you're going to do a shallow angle for your MLO. And so there's just different ways that you're going to try to get as much breast tissue on as possible. Take your time, be patient. Luckily, these are not the normal patients, so you're not going to go to work and have 20 of these type of challenges to deal with. You know, usually you're probably going to have one, maybe a couple in a day that are really going to be challenging for you. The other thing that they're talking about on this slide is a positioning aid called a breast cushion. What it is there's a little, it's about a 1/4 inch of a breast cushion that you can wrap around your detector plate, and it just makes it more comfortable for patients like these where that detector is really going to dig into their abdomen. So it's a comfort aid. Some facilities may have them, some may not. And always keep in mind that one of the worst things that can happen when it comes to safety in our radiology departments is for patients to fall in your department. So if a patient has compromised balance, then you always want to play it safe and have the patient sit on a chair for the MLO. Use a steeper angle on your MLO so that she's not getting into that position where she has to kind of lay back, where she can stand up straighter, or sit up straighter, which will help with them keeping their balance. And the other thing is, in most units, they default to where the minute the exposure ends, that compression releases automatically. You want to disengage that and you want to wait for you to come and disengage it, because sometimes when a patient is in compression and that thing disengages, they can lose their balance if they're very unsteady. And you want to be there with them when that happens. So that's why they're recommending to disengage the auto compression release. And then allow them to use their stability aids, have them near them, such as their walker or their cane. So for patients in a wheelchair, it's a good idea to have 2 technologists, because you're moving the chair around, you're adjusting the chair, and then positioning the patient and helping the patient. It helps to have a couple technologists. And like I said on the prior slide, this is going to be, the minority of situations. So if you have somebody that can help you, all the better. It might be helpful, and most definitely is probably helpful, to detach the armrests if you're able to. Some facilities have a mammography chair. You can always move the patient to a mammography chair. Just make sure that your chair is very safe. It has locks on it. You have 2 people there when you're moving the patient from their wheelchair to the mammography chair. Either way, you want to make sure that the arms are removed so that you can get that detector and compression device in up to the patient. You want to make sure that the lateral medial replaces the MLO, and you will remove the face shield when you do this so that you're compressing the lateral medial tissue instead of going medial lateral oblique. It depends on the patient. Some patients may be confined to a chair but are very mobile from the waist up and can get into the positions that you need. You may not need to make those changes, but just remember there's always that lateral medial approach versus the medial lateral approach in these challenging situations. We talked a little bit about implanted medical devices. Most often it's a pacemaker or defibrillator of some sort, or it could be a vascular access port. And as you know, these sit right under the subcutaneous tissue of the patient's upper chest. And so you want to make sure that when you're compressing the breast, that you are missing that. You're not getting that under the compression paddle. That could be very dangerous. Not to mention it's going to show up on your images. A lot of times the breast, the side that has the implanted device, you might want to approach the CC from below. And again, you might want to do the lateral medial approach to come from the lateral aspect of the breast, and then you're not bringing that compression paddle down across that implant. On the affected breast, or the side of the breast that the device is implanted, you want to, if you can't get the device out, if it's where it's implanted, you can't get it out of the field, then you want to make sure you do minimal compression. Otherwise, you want to exclude the device and compress normally. You're going to have cancer patients that come in, and they're going to have issues that complicate the examination. They're going to have physical irregularity. A lot of times these patients have had not only their surgery, they've also had radiation to the breast, and it changes the shape of the breast because of the surgery. It changes the texture of the breast tissue because of the radiation, depending on what part of their therapy they're in. Also, there's going to be some discomfort for them because of just their ongoing treatment, and the patient may be in an emotional or psychological state that you're going to have to deal with and understand. Of course, there's always the fear of the unknown. However, I have to say that most of the time cancer patients, unfortunately, are very experienced patients. So at this point, they probably are not going to consider mammography territory as the unknown. Patients with a history of breast cancer, they do have the increased risk of developing cancer in the contralateral breast, so you want to keep that in mind. Usually, it's a primary, not a metastasis. So in other words, it was something that wasn't picked up yet. It's no longer possible for the radiologist to make comparison between the breasts because the other breast has had surgery done or the breast has been removed. It's just, you need to keep these things in mind. A 3-view breast study gives the radiologist a higher probability to diagnose a new malignancy. So if you do have a patient come in that is a prior breast cancer patient, then you want to think about giving the radiologist an extra view. In addition to the CC and the MLO, it may be required to do a mediolateral view or an exaggerated CC view. It's just going to depend on the patient. On a post-mastectomy patient, early detection of recurrence will have an impact on the patient's survival. So physically, occult recurrence evident along the chest wall and the axilla and along the lateral rib. So this reoccurrence occurs in the most difficult areas of the breast to image. So 3 views can be performed as a standard of care, and make sure that you examine the prior mammograms to note characteristics of the original tumor. Standard views for these patients would be your CC and MLO projection. You may need to do a spot magnification in an area of interest or additional imaging to include the axilla. So an axillary tail of the breast view or exaggerated CC to show that part of the breast. This slide here shows imaging that was done on a post-mastectomy patient. Not all facilities are going to require this. They would probably do it if it's requested by the ordering physician, or some facilities may have this as part of their protocol. If you are imaging a post-mastectomy patient, you want to do the traditional views. And think of it as imaging a male breast or a very small breasted patient. So you're going to do your traditional CC, which you see in image C. The technologist is preparing for the CC. And then in image D, as in dog, it's showing the MLO. So you can get enough breast tissue all the way up to the axilla onto that plate. For this particular patient, they went back and did a magnification view in B. And then you can see that the magnification view does show an area of interest in A. So it is important to do your best and get as much tissue on the image as possible and do those extra views to show the areas of interest. So that's it for this chapter 8. I will talk to you on the next chapter. Thank you.